And welcome to the Dr. Bob Show. We'll be spending most of this show talking about breast cancer. We're doing a better job at diagnosing breast cancer. We're doing a better job at treating breast cancer. Despite that, 250,000 new cases of breast cancer in the United States will be diagnosed this year. 40,000 women will die of breast cancer this year. Who is at risk for breast cancer? Is there something that can be done to prevent breast cancer? Yes, there's something that we can do. My guest is Dr. Paige Johnson. Dr. Johnson is a board-certified OB/GYN doctor, and she'll be answering our questions on breast cancer. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about heart failure. Why do people get heart failure? What are the symptoms? And what can be done for heart failure? And low back pain, a problem causing misery in lots of people in the United States, a major cause of disability. We're going to find out what we can do to help you if you've got low back pain. A lot of information. You'll want to stay tuned. We're talking with Dr. Paige Johnson, board-certified OB/GYN physician, and we're talking about breast cancer. What can we do about it? There's going to be a lot. Paige, welcome to the Dr. Bob Show.
Thank you so much for having me. You know, I love to talk about women's health, so I appreciate you bringing me on today.
And it's so great to have you. Tell me about breast cancer. How common is it?
Well, actually, breast cancer is one of the most common diseases women experience, second to heart disease, and about 1 in 8 women in their lifetime will be diagnosed with breast cancer. 1
out of 8, so that's something we need to keep on our mind. Do women worry about breast cancer all the time?
In my practice, absolutely they do. I hear about it and talk about it almost every day.
So are there different kinds of breast cancer?
Yes, there are, and they really have to do with what is actually contained in the breast. So there's really 3 main types of tissue. There are the lobules, which are where the breast milk is made, or the glands, and then there are the ducts, and those are what leads the breast milk out of the breast, and then there's the stromal tissue and the connective tissue, which kind of holds it all in together.
So you've got a breast that's there. What are the different kinds of breast cancer? In the duct or in the tissue or in the outside?
Well, the most common ones are the lobular, which is in the gland, or the ductal, which is the ducts that lead away. Way less common are the stromal tumors, which is the tissue in between.
So if you can find a breast cancer early, pretty good results?
Absolutely. As a matter of fact, today, over 95% of women are cured and don't have to worry about cancer for more than 5 years when they detect things very, very early.
So the important message there is be sure and see your OB/GYN doctor. Follow the instructions. So who's at risk? Is everybody at risk?
Well, when we talk about women in 1 in 8 being diagnosed in their lifetime, we're talking about if women live till they're 80 years of age. And what we know is that women actually are at higher risk the older they get.
Whoa, so age is one risk factor.
So age is the big risk factor. The other big one obviously is being female. Way more common in women, which is why we talk about it in women so much. But I have to be cautious and make sure that men do understand that if they were to detect a lump, that they need to be cautious as well, because it is still possible for men to be diagnosed with breast cancer.
So men get it, women get it, much more common in women. Excellent survival rate if you find it early. Other risk factors other than age. So you don't stop getting your mammograms at age 60 and 65.
No, and really truthfully, that's sort of one of those things that we counsel women on a lot. You know, as we age, we know that women between 60 and 70, about a 30% chance are going to be diagnosed with breast cancer. The 30% of breast cancer are diagnosed in that age group. So the older you get, the actually higher the rate of breast cancer. But the hard part about it is that we do end up with other diseases that sometimes become more prevalent, more prominent, and more likely to be of greater concern when we're talking about balancing that with the diagnosis of breast cancer.
So as far as breast cancer goes, other than age, what are some of the other things like age of menstrual cycle, about when you go through menopause,
Right.
and when you tell me about
So
all that.
other risk factors are if you had started your menstrual cycles very early, or if you go through menopause really late. So therefore you're going to be exposed to your hormonal cycles for a much longer period of time if you start early or end late. Other risk factors would be a first-degree relative who's been diagnosed with cancer. Now, fortunately, the vast majority of women who have a first-degree relative still won't develop cancer, but they definitely have a higher risk.
How about if somebody's had breast cancer on the right side? What are their chances?
Definitely going to be at higher risk for getting a cancer on the other side. So if you've ever been diagnosed with breast cancer, you're at higher risk. Women that have very dense breast tissue are at higher risk, and we think that's in part because that tissue is more concentrated. There's more of it there.
So increased breast tissue density.
Yes.
Is that in big busted women, or you can have high density in the little breast?
It could be in either one. We do tend to see it a little bit more commonly in women who are of lower weight, but we know that obesity actually increases your risk of breast cancer as well. And there's a thought that it's because the fat cells convert peripheral hormones to an estrogen that actually increases the levels of hormones that circulate in the body.
So it's the estrogen that's really, in general, stimulating. So that's start your menstrual cycle early, you end menopause late.
Yeah.
That's because you're exposed to estrogen. So what does breast cancer look and feel like?
Well, you know, it's difficult because most of the breast cancers that I see, fortunately, are going to be in individuals who couldn't feel them and who went and got their routine regular mammogram, and they were diagnosed when it was still very, very small.
So when do people, then a mammogram is a key. So what are the indications for mammogram? Because there's always been a controversy about that.
Well, there is, and it really depends on your family history and whether or not you had a first-degree relative that was diagnosed. We say take what time in their life they were diagnosed, that age, and subtract 10 years, and that's when women should begin routine screening yearly. If you don't have a family history, there's a little controversy about whether women need to have a routine mammogram yearly between the ages of 40 and 44.
What do you tell your patients?
I tell my patients yearly, and the reason
I do
why
too.
is because, well, if the purpose is to diagnose early and to get it and treat it early, we know that cancers between 40 and 50 have a higher aggressiveness. They tend to be a little bit more advanced when we find them. So I feel like, why would you take the chance between 40 and 44 of missing a tumor that we could have taken care of earlier?
Are there changes in the breast that you can see or that you can feel if somebody has a tumor?
Absolutely. So things that we tell patients they need to be conscientious of. Obviously, if you are routinely kind of know what your breast tissue feels like. I always tell people the shower
In the
check.
showers, the
Right. Just kind of give them a good going over when you're washing. If you know what your breast tissue feels like and you kind of know that breast tissue is a little bit lumpy bumpy, but you feel something that's distinct and different for you, that needs to be brought to a physician's attention.
What does orange peeling mean?
Orange peeling is typically going to be this sort of swollen edematous, sort of pitted looking appearance. And we've all seen an orange peel. It kind of looks sort of bumpy and has little pits in it.
And so that's what the
sort of what the
outside can
skin
look like.
Typically, those are going to be a little bit further along, and that's not typically the first symptom a lot of my patients will see. They may also feel a lump or a bump in their armpit or sometimes between their breast, and those can be where the lymph nodes drain, and sometimes they'll diagnose themselves or feel a lump there. Other things to look for is if you look at yourself in the mirror and you see your breast, if one of them appears to be different or seems to kind of pull in one direction. The other thing in the nipples are very important to keep an eye on as well. If you've always had outward extending nipples and all of a sudden one of them retracts inward or tends to have a different sort of location than it has in the past, those are very, very important.
It doesn't go away by wishing it away.
No,
I
it
think,
doesn't.
You know, a lot of times people, well, maybe that lump will go away. Is there a certain time of the month with their menstrual cycle that they should shower up and feel breast?
Absolutely.
More so?
I usually tell women that the best time is not right before their period. So typically after their period, sort of in that week after their period, that's kind of when the hormones are a little bit less geared up and revved up. And women typically will be able to have less tenderness of their breast as well. And they're not going to feel things that maybe won't be there the next month.
So if we find breast cancer Is there good treatment?
Absolutely.
And that's what we're going to be talking about when we come back. Absolutely. That means there's things we can do where you'll do well. If you detect breast cancer, don't be afraid of it. Be afraid of not telling your doctor about it. We'll be right back. We're talking with Dr. Paige Johnson, board certified OBGYN doctor. We've been talking about breast cancer. We've been talking about the risk factors and what it feels like. And is there something we can do if we find it? Absolutely. So what can we do, Dr. Johnson, if we find out somebody's got breast cancer?
Well, first thing I always reiterate to my patients is this is not a death sentence.
They must feel so good when you say that.
That's the word. Your mind goes to the worst place imaginable. And for the patients that I see, they're mothers, their wives, their daughters. And so they automatically start to think about all of the things that their life might be limited. And so that's what I want people to hear, is that just because you're diagnosed, there is so much that has to be done and that can be done. And I don't want people to automatically start to fear what's coming next.
So what do we do next? Absolutely, there's things we can do.
Absolutely.
How do we find out what we need to do?
Well, so really it depends on the diagnosis and how it was made. So there's size, and then two,
size of the tumor.
And then two, there's a biopsy that's typically done in order to confirm that diagnosis.
Now, explain a breast biopsy. What's a biopsy like?
Well, actually, I had the fortunate event that a patient of mine had to have a breast biopsy not too long ago. And it just so happened that I was in a place in my day that I was able to pop over. And I sat and I held her hand while we did this biopsy. And it'd been a long time, Dr. Bob, since I'd seen that done. And I'm so thankful I did, because I can now relate to women what's going to happen. She did amazing. But what they do is they numb the skin, and under ultrasound guidance or with some other technology, they identify where the tumor is, and they actually take a little bit larger than average needle, and they pass it through into the tumor.
Under the guidance of X-ray, and it's all numb.
Right, and it's all numb, and it takes sort of just a little sort of, I say, scoop out of the tumor, and then they are able to send that tissue off while they're looking at it, knowing they're in the right place, so that tumor can be evaluated. And that's absolutely critical to what comes next, because knowing what kind of cancer, what kind of receptors are on that cancer will allow us to then help the patient individualize what happens next.
So you say there are different receptors. We're getting smarter and smarter on this, and so we know what kind of treatment, if they've got what kind of receptors. There's two of them, apparently.
Well, actually, there's three, but the two important ones that we hear about a lot are the estrogen receptor.
Estrogen receptor,
right?
Is that the more dangerous one?
Well, you think about it, if it's got an estrogen receptor on it, that means that it will take a woman's estrogen, and it's like fertilizer. It allows it to grow. Then there's progesterone receptors as well, and those mean that the tumor is responsive to a hormone that circulates in a female's body. But the advantage is that we can also use those receptors to help turn the tumors off or to shut them down and to prevent recurrence.
So is medicine specifically for the estrogen receptor and specifically for the progesterone?
Absolutely.
That's phenomenal.
Yeah.
You know, tell me about mastectomy. Tell me about taking out the breast, taking out part of the breast. You know, some ladies will feel like that takes away some of their feminine personality. Tell me about mastectomy, because I want to get into that, and one side, both sides, why, which, what.
So all women who are diagnosed by a biopsy typically are going to undergo some sort of surgical procedure. And we kind of lump them into two categories. One would be like a lumpectomy, where we remove the tumor in itself and all of the tissue around it. And then we actually can use a tracer that gets injected to the site where the tumor was, and then it will travel to the closest lymph node.
Oh, that's called a what?
A sentinel node.
Sentinel node biopsy. So you find out that would be under the arm from the breast, it drains up that way?
Wherever the tumor drains to, they will be able to find that first node that it lands on, remove that node, and maybe a node or two around it, and send those to see whether or not this tumor has metastasized or moved beyond just the breast tissue.
And the pathologist can tell you how aggressive, how mean, whether it's estrogen receptor, progesterone is. What, just from the breast tumor or from the lymph nodes, or
well,
how does he know what to do?
From the breast tumor, but then too, whether or not that tumor has traveled to the lymph nodes, which tells us at what stage it is. And so that's very important in consideration, because typically most women, when they consult with a surgeon, have had some sort of imaging like a CT scan or an MRI, so they have a good idea about whether or not those lymph nodes might be positive, and the surgeon will then counsel the patient about what types of surgery might be best for her. So some women will prefer a smaller surgery, not removal of the whole breast, and doing a sentinel lymph node, and then leaving it in the surgeon's hands from there about what needs to be done.
Leave it in the surgeon's hand or the OB/GYN doctor's hand?
The surgeon.
The surgeon's hand.
The OB/GYN really is, my job is to help get women to the place where they're diagnosed, do their prevention, and then make sure that women that are at higher risk are being screened appropriately.
Do you get genetic counseling, and what does that mean, and what does that help you where we are right now?
Well, in my career of 18 years, we didn't have gene, we just kind of heard about it, it was just coming out, and now we've got so much more that we know. We know that there are actually lots of genes that can increase the risk that a woman develops breast cancer. But from that also, we know that there are two genes that are most likely or are most prevalent at increasing a woman's risk. Fortunately, they're relatively rare. There aren't a lot of women in the population that actually have this gene, but it's very, very important to ask a woman about her medical history and her family history, because women that have close family members that are diagnosed with cancers when they're young are at higher risk for having one of these gene abnormalities, and those women need to be counseled appropriately about the pros and cons of undergoing gene testing.
So that's, if I remember correctly, that's BRCA1, which is breast cancer A1 and A2. If those are positive, you think about what in surgery, and what do you think about the ovaries, and what do you think about other family members?
Well, so we know that women who have breast cancer gene positivity have an increased risk. Some will say 50, some say 60, some say up to 70% chance they could develop breast cancer. But they also have an increased risk of endometrial cancer, ovarian cancer, and colon cancer. So individuals who are positive for a genetic abnormality that increases their risk from cancer will also need to know that whereas we need to address the fact that they're at increased risk for breast cancer, what about their ovaries? How do we screen for that? And colon cancer screening, very, very important. They're at higher risk for developing colon cancer, and at younger ages we'd recommend screening colonoscopies.
Ovarian cancer?
Ovarian cancer, I mean, we really feel as though today in the world that ovarian cancer has a much higher genetic or predisposition component than we originally thought.
So before we run out of time, if somebody has an abnormal genetic counseling, an aggressive tumor, how do they decide unilaterally take out the whole breast, or whether they should take out both breasts? Or what are the chances, if you got it on one side, that you're later on going to get it in the other side?
And that's why the surgeon is very important for a patient to feel comfortable consulting with their surgeon, because that's something that is really important for them to ask. What do I do? Should I take both breasts at one time? If I do that, what options do I have? And you know, today plastic surgery's come such a long way, but there definitely are some pros and cons to that. Very thin women without a lot of fat tissue are going to have have a little bit harder time with the reconstruction, may require expanders, may not be able to have their reconstructive surgery done all at the same time, and might have to have surgeries done in stages because of that.
Who gives that counseling?
The surgeon, and the plastic surgeon.
And the plastic surgeon. So there's a team.
There is a team.
OBGYN surgeons, plastic surgeons, genetic
Oncologists,
counseling, oncologists,
pathologists.
pathologists. Back in the old days, it wasn't that way, was it?
No, it wasn't.
Paige Johnson, you're unbelievable. You're one of the best teachers I've ever had on the Dr. Bob Show.
Thanks,
You've got
Dr.
more information than Carter's Got Liver Pills, and I thank you so much for taking your time to come and teach us about breast cancer, prevent it, exercise, eat properly, do all the things we say on the Dr. Bob Show. That'll make less chances of getting breast cancer.
Absolutely.
You're a wonderful teacher. Thank you. Come back again with me.
I will. Thank you, Dr. Bob. Appreciate it.
Unbelievable information. I hope that you're able to tape this show and keep it back. It will be helpful to you no matter what age you are. Now you're going to want to stay tuned. We're going to be talking about heart failure. Does that mean the heart stopped? Or what are symptoms of heart failure and low back pain? What do we do for that? A lot of information for you. You're going to want to stay tuned. I want to thank Dr. Paige Johnson. Wonderful discussion on breast cancer. Prevent it, cure it, live a good life. And now for questions from you, the viewer, that I think will be important to your health. Question number 1, Dr. Bob, a friend of mine had heart failure. Does that mean the heart stopped, or what does heart failure mean? It's sort of a cute question, but it's sort of really a very realistic and very good question. Heart failure, we usually are using the words for congestive heart failure. That means the heart is not pumping well enough. Why does the heart not pump well enough? Well, it could be that the coronary arteries don't give enough nourishment to the heart and it gets sort of weak and it doesn't perform. Or it may be that the lining of the muscle in the heart is having trouble. So if the heart doesn't pump out blood, then the rest of the body gets congested. It fills up with fluid because the heart's not able to push it around. That's congestive heart failure. Symptoms: shortness of breath, swelling of the feet, waking up in the middle of the night with air hunger and shortness of breath. Sometimes a frothy, foamy, bloody sputum because the lungs are congested. So if any of that happens to you, you have to see your doctor. It's a very serious thing. There are new medications, new procedures, new things that we can do for congestive heart failure. So don't be afraid of it. Be afraid not to tell your doctor about it. So if you get symptoms, swollen feet, short of breath when you shouldn't be, chest pain, chest discomfort, and you know something's wrong, you just are tired all the time and you just don't feel good with swollen feet, talk to your doctor about, do I have congestive heart failure? Second question, Dr. Bob, I have low back pain. What should I do? Well, everybody gets low back pain every once in a while. It's that part of the low back. That's where the spinal cord nerves that come out of the vertebra are suddenly pinched and everything goes into spasm. Or it could be chronic low back pain that people have every day. We all know that there's an epidemic of opioid overuse, and it's a person with low back pain that needs something for pain. There are other things that we can do. So if you get an acute flare, the literature says, listen to your body, get in a comfortable position, sleep in a comfortable position, don't sleep on the floor, don't sleep on a flat board, because if anything, that might even make you worse. And know that if it persists longer than 2 weeks or 3 weeks, then there's something you're going to have to do about it. If you get sudden back pain and you get loss of feeling of your feet, or you get foot drop where your foot won't pull back up, or you get bladder incontinence, now that's 911. You get to your doctor right away and you get to the emergency room right away. But that usually is not the case. So people with chronic back pain, there's now neurosurgeons and low back pain doctors that have special techniques where they can fix the spinal column. to where it doesn't put pressure on those nerves. And when it doesn't put pressure on those nerves, then you don't need pain medications. So our goal should be to be pain-free, to be as good as you can be, to be active, to stay active. And if you're able to stay active, the muscles around the back will protect the vertebra, or the doctor can protect it, and you won't need to get hooked on to opioid medications. So remember that. There's lots of other good pain medicines. Your doctors will guide you toward those. We want as much as we can to use alternating heat with ice on the low back or where the pain is. There are lidocaine patches that we can use, local anesthetic patches. There's mindfulness. You know, that really sounds interesting. The mind can really begin to control pain. And so know that there are new things. Listening to music may help your mind get off that pain. So don't get hooked on those pain pills, because they can lead you astray and you can get hooked onto those. Be sure and talk over your low back pain with your doctor if you need to. And now remember, that's all the time we have for this show. Those 4 things that we like. What is the first one? Exercise. Most important thing we can do, no matter if you're old or if you're young. Get those tennis shoes out and go for a walk. Have a good time. It'll lower stress, lower your blood pressure, make you feel better. You'll get a runner's high. Endorphins will come out. Get 7.5 hours of sleep. How do you do that? Well, you get prepared to sleep. You make sure that nothing's interfering with your sleep. You go to bed at the same time. You wake up at the same time. There are now there's technology that tells you how to sleep good. Be sure you're eating properly. Eat well. Eat properly. Don't eat a lot of bad foods. You know what the bad foods are. And now, most of all, what do we like in the Dr. Bob Show? You know, it's that laughter in your life. Laughter helps the immune system. It helps the immune system work better. If you laugh and you giggle a lot, you feel better. The people around you feel better. So remember, laugh a lot and you'll stay healthy.